You need to be involved. ASHA, state associations, journal groups, through the Bilingual Therapies blog, posting comments. I'm still waiting for my first comment on the blog that I did or the little video that I did for Bilingual Therapies. Again, I think we have a community here, and certainly this company has for a long while now provided a forum for us to interact with each other. I think we need to do more of that. And also change, be willing to change, not only yourself, but also those that you work with. I would imagine that you're under tremendous pressure from your supervisors. Maybe there's somebody who's a supervisor here in terms of the number of kids that you're seeing, the number of kids that you're evaluating, especially when you are bilingual. It doesn't mean you're just Spanish-English bilingual. It means you're Swahili-English bilingual. I'm actually doing a diagnostic group at Temple this summer, and we've seen a kid who is Arabic-speaking, and on Monday morning we have twins who speak English and Amharic, which is an Ethiopian language. So I think the clinic director said, "Oh, you're bilingual. You must be able to see anybody who's bilingual." And I think we're often put in that position, right, to somewhat extend ourselves in a way that we might not be able to. And again, so I think educating and standing up for what our needs are and interacting with those above us to say, look, this is feasible, this is not feasible. And I think if we can do that, then not only are we looking at interaction in terms of languages within bilinguals, but also how we can interact in the system to provide better clinical services for the children that we assess and treat. 59 minutes. A couple questions? This is my Guitar Hero pose. That's like my new obsession. Have you played Guitar Hero? Don't start. You won't be able to stop. I'm seriously having Guitar Hero withdrawal. My wife keeps telling me I've become a Guitar Hero widow. Okay. If I talk about it, I feel better, so thank you. Questions? Or comments?
Final consonant deletion. When you're looking at that in English, when do you look at it as maybe it might be an influence from Spanish, and then you're looking at difference versus disorder? That's my question.
Cross-linguistic effects or transfer, I think, is one phenomenon that have been studied in bilinguals perhaps more than any other. What's interesting, though, is that people have talked about cross-linguistic effects since, I think, the advent of the literature on bilingualism. What's most interesting to me is the fact that how low the frequency of occurrence is of cross-linguistic effects. So when I look at it in phonology, for example, it's almost always less than about 10%. So about 10% of the, I don't want to call them errors, because I don't see them as errors in the same way that initial consonant deletion is an error. But if I look at things that are not the same as what we'd expect for the target, it's usually not more than about 10%. So it's a relatively low frequency kind of phenomenon in the first place. So I think one way to tease it apart is to do some trial therapy and seeing, can the child put on final consonant deletion, put on final consonants, but simply doesn't because of transfer effects, or is this a aspect of the disorder? So I think you're looking at it's a frequency issue. Again, it's going to be relatively low frequency. If it's a transfer or cross-linguistic effect, much higher if it's a truly disordered pattern. Everybody needs more coffee. Oh, sorry, yes.
How do you interpret the data clinically, especially in group studies? You had mentioned...
So how do you interpret the sort of group study and then apply it? I mean, I think we have to look at the group data and say, this is what a group of kids, hopefully of the age that I'm working with, are doing. I think when you look at those studies, you need to look not only at the mean. For whatever reason, we're trained on the mean, looking at the average, but what we don't think about is what's the range, what's the standard deviation. So I think we need to look at our individual kids, not are they at the mean, because mean doesn't indicate, I'm trying not to use the same word. The mean doesn't indicate normal or typical or atypical. I think that's what our mindset is. I don't know if it's from training or from standardized tasks or from bad karma. I don't know what it is. But we think if somebody is lower than the mean, that's a problem. No, that's not necessarily a problem. So I think the way to interpret group data is actually not to look necessarily at the mean, but look at the range of scores or whatever's being measured in a group study and say, does my kid fit within the standard deviation? It's also why when you do use standardized tests, it is so critically important to do the confidence interval. Right? You often see those on the front page, and I know, sometimes you're in a hurry and you don't do them. But what it's saying is that, look, here's the range of scores I would expect this kid to have. They had administered this test 100 times, which, sure, go ahead and do if you want, but I don't think your supervisor or you're going to be very happy doing that. So look at the range instead of the mean, or in addition to the mean. Don't get fixated on that. Any other questions, comments? Let's break.